open it up. Good afternoon, everybody. We're going to give it just another minute while we have everyone joining from the waiting room.
Hey, can you hear me?
We'll get started in just a minute. I'm going to give it one more. We've got a lot of people signing on. Happy Monday. Okay, we'll jump in. So welcome, everyone. Thank you for joining us for this is now our third TEFCA Public Health Community of Practice being led by the Office of the National Coordinator for Health IT and CDC. I am Liz Abbott. I'm a contractor with HLN Consulting, supporting the facilitation of the COP along with other HLN, ONC, and CDC colleagues who are on the call. So just a brief overview for today, we're going to focus on some of the more technical aspects of TEFCA, and we will specifically cover how TEFCA fits into CDC's broader public health data strategies, as well as hear from ONC related to how FHIR fits into the TEFCA framework. And then we should have plenty of time to hear from you all. We'd love to see if you have any reflections from our May meeting briefly before we dive into those presentations. And then we'll have Q&A and discussion time related to the content that's shared today. And so just following today's meeting, you should be more familiar with how TEFCA fits into CDC's overarching public health data strategy, as well as have a clearer understanding of where FHIR has a role under the broader TEFCA framework. So these are just a few housekeeping items and reminders before we get started. Please go ahead and rename yourself to include your agency, state, or your association acronym. Feel free to introduce yourself in the chat if you'd like, and then please stay on mute when you're not speaking. And then for the discussions and Q&A, you can use the chat or select the reactions icon to raise your hand. If you have any technical issues, please reach out directly in the chat to Lux and let her know. And then you should have been notified when you joined, but this meeting is being recorded and we'll share the link with you all when it's ready following today. So last month, we were fortunate to hear from 4 jurisdictions on kind of their great early efforts related to TEFCA, getting started with TEFCA. And we heard from Alaska, Fairfax County, Southern Nevada Health District, and Washington State about their experiences and their challenges and any advice they had from you all. So it was really wonderful and a full agenda, kind of with a lot of information provided, and we didn't have a lot of time for discussion and Q&A. So we did want to offer a few minutes today. If anyone has any reflections that you'd like to share from that session, please go ahead and raise your hand or type in the chat. And we would just, love to hear if you were left with any like burning questions, had anything you wanted to hear more about, or general reflections related to any or all of the panelists. So I'll give us just a minute there to see if anyone wants to share anything. Looks like Chris, do you want to speak up at all, since he's excited about the query response use case and would love to hear from Fairfax after they use it? Do you want to elaborate any more on that, Chris?
Yeah, it's just I think there's so many amazing use cases within public health for that query response, and it's such a point of um, it causes a lot of additional staff hours, to do what needs to be done today, and if that truly can provide a singular place for staff who are doing those investigations or long-term follow-up, like I said, we've thought of a lot of different ways that could be leveraged. That's a really exciting one to me. So I would love to have Fairfax, if they're interested, come back and share with us their experience. I'm also curious too if there's a way for them, to like compare, like, did you get from TEFCA what you expected based on other queries you may run today? I think that's the big question with query response. Is it probably isn't going to be nearly as effective until we get good uptake from all the healthcare organizations. And so very curious too if that's something CDC and ONC can share along the way. Is what does the uptake look like from our ONC or from healthcare organizations? What percentage of Epic use customers, for example, are going to be live by TEFCA by when? Having some of that information would be really helpful.
This is
Thank you,
Steve.
Chris. Go ahead, Steve.
This is Steve Eitner. To build on Chris's comment, very much interested in that. Very much interested in being able to access information about what providers are connecting into TEFCA, not just from a percentage perspective, but more on the ground information, because that's really going to drive a lot of what we expect out of TEFCA from a usability standpoint. If we're looking at doing searches, understanding what the provider community is that we're searching for or searching data from is really, really important. I understand that ACR may leverage some of the TEFCA components. I am curious about how that's being bridged with respect to providers that have not signed a TEFCA agreement, as to whether their data is going to continue to be available through ECR. And again, how is that going to be navigated and shared about, hey, this provider is participating in TEFCA, this provider isn't, and what that means and how does that look like? Action might be required on public health to get support, encourage providers to sign, or are we looking at a potential data gap in that space?
Thank you so much, Steve. I think some of this may be spoken to in some of the presentations today, and then I know that we've discussed the query response and some other topics for future meetings. So we will make sure we record all of these topics, and I love to see the conversation happening in the chat. It looks like California has connected with Chris here, Tamara, related to some of the FHIR PowerPoints that Chris has given, and we have a lot of other topics that we can track to share out with you all. So I'm going to hold off on any other questions that are in the chat right now, and we will have time for discussion just in case any of these are touched upon through the presentations today. And we're going to have, again, plenty of time for discussion and Q&A shortly. So we'll come back to these and others that come up. But thank you for, kind of just bringing us back to some of those topics that we started to raise. And it's great to see kind of you all having these joint conversations through the chat. So feel free to keep that going. I'm going to now pass it over to Kyle Cobb to talk about TEFCA's fit into CDC's public health data strategy. And so here are two links that I know Kyle is looking forward to sharing and speaking to. And Kyle, let me know if you need me to pull up anything or if you want to take over the screen share.
Okay, thanks, Liz. And think I can take over the screen share, but we're gonna just go to the interoperability site. If you want to just click on that. So just quickly, hi everybody, Kyle Cobb. I am the Deputy Director of the Data Policy and Standards Division in the new CDC Data Office of Public Health Data Office Surveillance and Technology. And I think I've spoken with many of you over the last several months around TEFCA use cases. We have been working here within the office to really identify some of the early demonstrations of public health and TEFCA, and see that we play a really critical convening role for public health through our office to identify the different use cases as we've been chattering about in the chat, but also to really be able to link them across the nation. And so we've actually done a pretty significant deep dive with about 20 stilts to date, and are sort of putting together an overview of what these different use cases look like that we hope to start bringing back to this COP, and then as we talk about how we transition this to the implementation center COPs in the future. So a lot more to come with that. Steve, I see you have a hand. Yes, Steve? No? Okay. Well, come back. We'll come back to you. But what I wanted to talk about right now was not necessarily the use cases, but how the TEFCA actually fits into the bigger public health data strategy, and or the PHDS, for which we have TEFCA as being a really critical and key part. So Liz, if you can just click on the link for Health Data Interoperability site, we're going to go to the CDC's new, beautiful, just released website. And yeah, and if you scroll down a little bit on featured sections, if we can, the strategies for public health interoperability, if we can click on that. I know we're trying something different, but this is perfect. Instead of trying to get slides through clearance in advance of meetings, we're just using websites of public information, which I love, and I think our e-clearance people do too. But the idea here, and many of you may have seen this slide in sort of different incarnations, or this image in different incarnations, but really what we're trying to do is pull everything together and connect the dots on the work that we're doing around modernization. So, and I think in some ways TEFCA may be sort of at the top, or it's the icing as well. After you've done all of these things, specifically starting with, right now there is public health certification criterion with EHRs going to public health. And there have been discussions, and ONC has signaled that in future rulemaking, it will be expanded to a public health agenda. So we're looking at that. We also have a whole push to move from older standards to FHIR as part of the strategy. We have implementation centers working closely, will be working closely with stilts nationally to get them moved onto new infrastructure, including standards, so into systems that are conformant to these standards. And USCDI and USCDA Plus as being our content vision for what are those minimum data necessary for exchanging across public health to public health to healthcare, healthcare to public health to federal. So we're looking at sort of all of these different scenarios. And this is I will just say that the USCDI Plus part is really a work in progress. But when this is all done, we see this as being a way that articulates what all those different data are that we're exchanging through at the very end TEFCA, where we actually have the pipes for the connections across all of these different types of exchanges between public health and healthcare and CDC. So that is really sort of where we see this whole strategy going, and all the parts that fit together. We will, talk, I believe the next months we'll have some more work where we talk with our partners in the Helios Accelerator about how we're actually pulling that thread a little more, taught through them, but really working with, our FHIR accelerators to make sure that the testing and what we're doing aligns with getting stilts modernized and ultimately connected to TEFCA. So I'm going to just pause and see if there are any questions from people. And I'd love feedback as well, if you don't have necessarily a question.
It looks like we do have a question in the chat. So what is the benefit for states with implementation centers? We're concerned it will not address the resource constraints we have as we need hands on the keyboard to implement TEFCA.
Got it. So I want to hear a little bit more about this in terms of the addressing the resources. So I think there's sort of two, and my understanding is implementation centers are doing work that will incorporate getting, helping stilts join TEFCA through understanding what those agreements are, how that actually works. There may be even in-kind services around that whole process. There also will be additional awards or budget that will go to modernization of systems where needed. So Lynn, does that, I'm not clear on what the hands-on the keyboard to implement TEFCA is. Is it from a policy and legal perspective, or is it from a technical perspective?
I think from both.
Okay.
Obviously, I think, and also maybe that's just the fact that we don't have a good understanding of what, the implementation center gonna do to support, the state, for TEFCA,
Yeah.
right? But, we have gone through that with a number of mechanisms from, CDC for technical assistance, before.
Yep.
And, why, a lot of advice is really great. At the end of the day, we still have to have, people who actually do it. And
Yeah.
that's, the concern that, we have.
Yeah. I think that, we have been seeing that as well. And one of the areas that I think our team at CDC will be most helpful in supporting this work is being able to come up with some aids, and really understanding, so you want to join TEFCA, what does that mean? What do you have to discuss with, your legal folks, and what does that mean when you, from a technical perspective, because TEFCA is both policy and technical, and we're very aware that there are lots of questions about what it means, and I think we're on the sort of we're T-2 weeks for about quite a few stilts going live on TEFCA, for which we'll be sharing more information, working with them to share information about how they did it. And I think a lot of this becomes sort of rooted in a COP, where folks that have done it can share their experiences. We can work with you to codify that information, materials for the ICs to share, but it really does become that community, informing work. And Chris, you have a question about, so in terms of the common DUA and DEX and TEFCA exchange, I will say that, this could all be possible, but just to step back a little bit for everybody that doesn't know what the common DUA or the core DUA work that CDC has been doing, but we have are in the process of establishing, or we have established a core DUA with response specific addenda across case, lab, and so forth, that for stilts that will be for, across, NOFOs and other agreements with CDC, But in the future, TEFCA could be the way that that information comes to CDC. We're at the very beginning stages of investigating how CDC would connect to TEFCA and what that means. And of course, there's like a lot of sort of understanding, you know, specific use cases so we can pilot them before we even get to, you know, our future state where there could be, you know, RCKMS or AIMS platform routing to, you know, a cancer registry and to CDC at the same time, for example. Or there's, you know, for cancer case reporting. There could be other scenarios like that. I don't imagine it would be just a full throttle turn on, but sort of those are sort of some of the ways that we could incrementally get there. Does that answer your question, Chris?
Yes, thank you.
Yeah, and I don't know if CDC would be, CDC would not be a QHIN. CDC would join a QHIN as a participant. And what we need to figure out is to join, in order to join a QHIN as an entity, you do need to be able to exchange data. So it wouldn't make sense for CDC to just be passively collecting data without having some way to push back into the network. And those are what we're trying to figure out with our programs right now, what those use cases will look like. But there definitely are ones where, for example, like the cancer registry use case, or there's, you know, MENS has pilots right now that we're looking at to see if that could be adapted to a future state of TEFCA. And there's others that where there are data that go to directly to CDC and other folks, and how that would actually look. So,
Well, this is Steve Eitner. I would
Oh,
think that the patient consent would be a part of that component as well as for pushing data back out. But secondarily, of considerable interest is looking at the role of state legislatures and state authority. That while we may be the state health department, we are responsible to the state legislature and need state legislature approval to undertake many activities and are beholden to them and need to follow their cycle. In fact, it's a biennial cycle, so we can't necessarily move all that quickly on implementing new technology, or you don't have authority to enter into an agreement and we need additional legislative authority. That's also a time element that needs to be considered.
absolutely. And that's part of the coordination with the core DUA work and the addenda, which are specific to the jurisdictional differences. And I think that's what you said is key. So again, this is all very, you know, nothing, it's speculative, and we're thinking about what this would look like. But another part of sending data to CDC would require it to be de-identified, which we also have to understand what that would look like and how we could keep it de-identified, linking with other de-identified data, and being able to push data back out on responses. So, right, like there are technical and very real technical that have to be figured out, and how they align to the jurisdictional legislature in terms of what data are shared, what data go back, and so forth.
And Kyle, thank you for all of this and for framing it out. I think we
Yeah.
probably need to move on to Chris, but we will have more
Yeah.
time to come back to some of this. And I think we are planning to hopefully cover more on the legal policy side of things at a future potentially August call, and can come back to some of that. But I know that there's still some questions. I am tracking those. Mary Sarah, I am not ignoring. I know you had an earlier one that I think we can come back to. So I'm noting these, and we will pass this over. Kyle, do you have any final comments before I pass over to Chris? And then we'll come back to you both. And
thank you for the engagement and the questions. And I think, you know, Mary, Sarah, yes, those are exactly the kind of things that we're starting to look at, because they'll be, you know, key to success and having trust in the network and understanding how the sharing works. So Thank you.
Thanks, Kyle. Right, so we're going to move into the portion where Chris is going to talk a little bit more about some of the technical components, including how FHIR may have a role in that TEFCA framework. So Chris is the ONC Networks and Scalability Division Director, and I will pass it over to you, Chris, and just let me know when you want me to flip to your next slide.
Yeah, great. Thank you very much. And hi, everyone. As already been stated, my name is Chris Muir. I am from ONC in the Office of Technology, and I'm the director for the Networks and Scalability Division. And among other things, my team supports the technical aspects of TEFCA. And I was asked to give a presentation starting off giving just a high-level overview of TEFCA, although it sounds like most of you already know quite a bit about it, but just for context, and then talk about how FHIR fits into TEFCA has already been explained. So if we go to the next slide. And this is our famous umbrella slide that explains how TEFCA works, and you probably all have already seen it, but I'll just touch on it because it gives some grounding for future comments I'll make. As I'm sure most of you are aware, back in 2016, a bipartisan law was passed known as the 21st Century Cures Act. And among other things, it required ONC to develop a trusted exchange framework and also a common agreement to enable exchange between health information networks. And it also gave ONC authority to define overall policy and governance required for nationwide exchange. And ONC entered into a contract with a recognized coordinating entity, or the RCE, as we call it. The RCE is the Sequoia project, whom we selected through a competitive process. The RCE provides oversight and governance for the Qualified Health Information Networks, or the QHINs. And QHINs have connectivity to each other to facilitate nationwide exchange. And under each QHIN, there are participants, which could be, for example, providers or state and regional HIEs and many others. And connected to participants are sub-participants, which are often smaller practices and other providers or payer organizations. They could also be public health authorities and really many other types of entities. But the idea is that you can be a small provider, for example, in one part of the country, and because of your connections to a participant and a QHIN, you can have access to providers in other parts of the country through these QHIN to QHIN connections. So let's go to the next slide. So again, for context, I believe everyone is aware that TEFCA is currently operating using SOAP-based IHE profiles between QHINs. And I think it's important to note that we do not specify how exchange occurs within a QHIN. QHINs have the autonomy to architect their internal networks, however works best for them. But the QHINs are responsible for following specific standards as they interact with other QHINs. The services within TEFCA, as this slide shows, include patient discovery, document query and response, and message delivery. TEFCA is initially using IHE profiles, as I mentioned, because that is basically what is being used in the market today. But I will provide some almost imminent updates to these requirements in a moment that, that contain FHIR. So if we go to the next slide. The TEFCA exchange purposes identify the reasons for which kinds of information can be shared through TEFCA exchange. And currently, there are 6 purposes that are allowed in TEFCA, but others may be allowed in the future. We initially identified treatment and individual access as the 2 types of exchange in which requires a mandatory response from those in the network that receive a request. We are developing standard operating procedures and identifying implementation guides to enable the other exchange purposes on this slide. And we'll eventually have other required responses for specific exchange purposes or sub-purposes. Next slide, please. Because FHIR API Exchange is the future for health information exchange, we wanted to message ONCs and the RCE's interest for including FHIR in our TEFCA plans. So we developed the TEFCA FHIR roadmap. And in fact, we have released a second version of the roadmap that happened late last year. We see FHIR being included in TEFCA really in 4 stages. And while the first stage is already taken place, it's the IHE exchange. Entities are able to exchange FHIR payloads with some out-of-band coordination, today. In stage 2, which will essentially be triggered by the release of the QHIN Technical Framework version 2, we call it the QTF, which we anticipate happening very soon. And the QTF and Facilitated FHIR Implementation SOP, another document that we'll be releasing, will contain specifications to enable point-to-point FHIR exchange using some QHIN facilitation for it to happen more efficiently. And I'll give you a quick example on how that might work. So let's say I'm a healthcare provider, wanting to find data about a specific patient, and I want to exchange using FHIR. I would first go through my QHIN to determine who has information on the patient that I'm interested in. And then through my QHIN, patient discovery would take place using the IHE profiles. Once it's determined who has information on my patient, I would also be able to retrieve their FHIR endpoints. And then with those FHIR endpoints, I could reach out to those other endpoints with those endpoints with some level of security orchestration, and I'll talk about that in a second. And I would be able to directly obtain data from those endpoints. We anticipate some TEFCA participants and sub-participants going live with facilitated FHIR exchange during this calendar year, 2024. It is important to note that supporting facilitated FHIR exchange is required for QHINs at this stage, but it is optional for participants and sub-participants to actually do that exchange. And then in stage 3, which we anticipate being in calendar year 2026, we will provide specifications for enable QHIN to QHIN FHIR API exchange. That capability will enable use cases such as using FHIR calls between QHINs to do patient discovery and FHIR endpoint retrieval. In stage 4, FHIR API exchange will be available following the same exchange patterns as that is used in IHE profiles provided today. So for example, it would help in situations where maybe a sub-participant will not want to run a FHIR server, but still want to offer and receive FHIR resources. So QHINs and participants will act as intermediaries for them. But just to be clear, these stages are not mutually exclusive, but they are in addition to each other. So we, one stage, once it's launched, it doesn't ever go away. We just continue to add functionality. So if we go to the next slide, please. So just to reiterate, the reason for the QTF version 2 was to specify what QHINs must do to enable facilitated FHIR for their participants and sub-participants. All other requirements related to facilitated FHIR exchange, including those things which will be required of participants and sub-participants, will be spelled out in the facilitated FHIR implementation SOP. We are still finalizing the SOP, but I am presenting what the latest draft includes, which should be pretty much correct at this point. The major thing that the SOP covers is the optionality we are initially providing for registration, authentication, and authorization. And the 3 options are first, the HL7 fast UDAP security IG. It's called SARA. That's how we refer to it anyway. And a second option is the Smart Application Launch Framework IG, coupled with the Smart Backend Services. And then finally, we allow actually other authentication and authorization frameworks as long as they adhere to the requirements of the QTF. And a primary example of that is some pairs use mutual TLS to connect to each other while doing FHIR API exchange. And in fact, that option is one of the options that are available in the DaVinci Payer Data Exchange IG, for example. However, the long-term goal is to eventually require everyone to use the first option, the SARA, because it allows for scalable registration and leveraging the trust community and the TEFCA certificates instead of having people use the traditional OAuth patterns of having first to manually register with each endpoint before obtaining access. And that just doesn't scale for a TEFCA-like environment. But because most EHRs and other systems don't yet support SARA, we are providing these options during the next 2 years until those other products such as EHRs catch up. Another thing I wanted to point out is that TEFCA largely aligns with the ONC and CMS regulations. We want to leverage the standards and functionalities that are currently in certified products. We will require the use of FHIR R4 along with the US Core 4.0. And just as a side note, although US Core 3.1.1 is in regulation and in certified products as the baseline, there are some backward compatibility issues with that version. And so we've gone to the next version, which, 4.0.0, which don't have those compatibility issues. Also, I want to mention that participants and sub-participants will have the option of using Smart Application Launch Framework implementation guide, as I mentioned before, which is also in certified products. And then just so you know, in subsequent versions of the QTF and SOPs, we will update requirements to align with the standards and other requirements based on the latest HHS regulation. And while not on the slide, there are a couple of other things I want to point out. FHIR servers should, not must, but should also support additional IGs, which include the bulk data access IG, which is also in certified products. But it also includes mobile access to health documents, referred to as MHD, which is an IHE profile that allows FHIR API exchange interaction with the IHE SOAP-based infrastructure. It also suggests FHIR servers support the DaVinci Payer Data Exchange and the DaVinci Clinical Data Exchange IGs, both for the purpose of enabling and encouraging payers to participate in TEFCA. And finally, if there are any conversions of data, it must be documented using the FHIR Providence resource. And so if we can go to the next slide. So also while we're in this 2-year interim period, we are initially allowing people to determine their own exchange partners to get experience in making FHIR API exchange work in TEFCA. And of course, because of the optionality, there will be some pre-coordination that will take place among the pre-selected partners. However, beginning in 2026, all those doing FHIR API exchange must support SARA and then must exchange with all others using SARA. And then if we go to the next slide. That concludes my presentation, and at this time I will try to answer any questions that you might have. And it looked like there were some questions in the chat, so maybe someone could help me, help me facilitate this question and answer session.
Thanks so much, Chris. I think we can definitely do that. I see most relevant to your slides, and then I'll go back to some of those earlier questions that that you may know a little more about, or Kyle may be able to come back and help answer. But it looks like, Chris, you asked how many FHIR payloads are sent today via TEFCA and who is using it. And then there was some discussion in there. So Angel with New York City, if you want to jump in and expand upon your response to Chris about your experience, that would be great too. But Chris, I'll let you start to address that.
Yeah, so about how many are taking place. we're not really sure. Honestly, it's not something that they actually have to report. I am guessing very little, to just be quite honest. I think most people know that the facilitated fire option is imminent. I mean, literally it'll probably happen in the next week or two. And because TEFCA is still pretty new, I don't think that's probably happening, but it certainly could happen if people wanted to do that.
Thank you. Antal, do you want to say anything else about New York City's experience with Hep C?
Sure.
And
We did a Hep C pilot as part of CDC's MedMorph project with AHRQ. It was a pure proof of concept. We did get some real data and did some analysis on it. We have an unpublished paper written by one of our partners in CDC on that. And it was very small pilot, and it took a lot of work. There were lots of challenges because the standard at the time, this is going back almost 2 years, needed to get more mature. And so we found lots of items that needed to be addressed and that we had to address on the fly. So it was challenging for all the partners, and it was challenging to find sites that were willing to do the pilot and to find EHRs. So we were lucky to succeed at that pilot. It was definitely a challenging one. More recently, we have a contract with HealthX to allow us to query them for reportable conditions. They are connecting to the Bronx Rio, so those are the two health information exchanges that serve New York City. So we're fortunate to have just two. And so we send the query to HealthX, they bounce the query to Bronx Rio, and they give us back the responses from both. And then we actually do some matching on our search record and the records that they return to make sure that the records are actually the people who we think they are. And then once we know the right people, we send a follow-up query to pull the health information that we need for case investigations and case management for our surveillance programs. That is in testing right now. It also has challenges. While we are testing, we are identifying challenges that we need to address. And so that's midstream. And the final one is a FHIR push from HealthX when a pregnant woman is HIV positive. They are pushing those records to us. So we're doing a perinatal HIV project as well. We are planning to expand these. We're starting with these use cases just so that we have a starting point. None of all of this work is pre-TEFCA. This is all pre-TEFCA work that's being done using FHIR standards. And the idea behind it is that we want to be ready to be able to process FHIR, whether it be via query or via a push to us. And our biggest gap right now is that we do not have a FHIR endpoint in New York City out on the internet. We're having lots of challenges with central IT in the city and even within our own agency who see the need for this to get a FHIR endpoint published out on the internet so people can push FHIR resources to us directly or send FHIR requests to us. So that's our biggest kind of infrastructure challenge at the health department in New York City.
That's great. That's very, very interesting information. And we'll probably touch base with you at some point as we go along and get some lessons learned from you. That sounds great.
Wonderful. Looking forward to it.
Thank you for sharing. I'll jump down. Can you resolve TEFCA's language regarding public health not requiring to respond to queries and the language presented requiring FHIR response? What transactions are you expecting to be permitted to be undertaken with FHIR? This is from Steve. Let us know if you want to expand on that anymore, Steve.
Yeah, so there are certain cases where even though some use cases, let's talk about like treatment and individual access services. Right now, those for most people are required responses if they get a request. We have done a carve out for public health, and for various reasons, and maybe there are people on this call like Rachel and Katie that have more insight into that, but we just feel like in some cases for public health, it doesn't make sense for them to have to respond like for treatment, for example. And then so for FHIR, which exchange purposes. So well, eventually FHIR will be used for all of the exchange purposes. But we think in particular there's some exchange purposes we think in particular people will be interested in doing and using with FHIR API exchange, which of course treatment and IAS, individual access services, and having apps be able to connect to those FHIR endpoints, we think that's a big one. We also think payers will be very interested in exchanging, using FHIR. They're from what we hear, for the most part, they're not doing IHE, and they don't want to do IHEs, but they do want to participate in TEFCA, so they want to use FHIR. And then I think public health also, the reason why we're here is also when there's interest obviously in public health doing exchange.
I muted for a follow-up, because one of our challenges is that the state of Texas, like many other health departments, has many of its systems that are in distinct silos and aren't integrated, don't have a master patient index, don't have and are nowhere close to a single FHIR server to serve a variety of our data needs or our data services. So looking at an integrated response or even being able to respond to queries for different systems may not be on the near-term radar map, may not even be in the midterm radar map. There's an awful lot of heavy lifting that would have to occur for anything like an integrated response. So that's a real challenge. That's part of why we talked and had the discussion about public health responding to queries and not being required to respond to queries, because if we do it across the board for our systems, that would be probably a stop that would cost us 5 or 6 or 10 years of implementation if we had the resources to do it.
Yeah, understood, Steve.
I'm going to jump back to an earlier question Mary Sarah Jones had from Amazon Web Services. She said, are the details or perhaps specifications being collected from all the pilots to promote repeatability? And is this information accessible to everyone? So Kyle, this may be a question more for you to speak to, related to kind of the learnings from these pilots and how those will be shared out.
Yeah, and I'm sorry. So which pilots? And I'm a little confused.
Mary Sarah, do you want to expand on your question? I think you're talking about the pilots that are working towards July.
Okay. So
I'm just coming back to that. I think that's right. And Mary Sarah, please correct me if that's wrong.
Okay, so there are, I mean, we've talked about a lot of different pilots, and there are pilots that are happening within Helios and demonstrations around TEFCA, but there are also a series of stills that are committed to joining TEFCA as early demonstrators by July 1st. And those are just examples and folks that have gone and joined TEFCA as participants or sub-participants, or in some cases where they're doing the ECR use case, haven't joined or just getting notifications pushed to them. But those are demonstrations of using TEFCA. And so we will be working to really codify, articulate what they are, how the process worked, back to sort of comments from before about its being, TEFCA is both a policy and a technical endeavor. So we will be working closely with, we imagine, this group as a COP, as well as whatever this COP turns into in the future is with the implementation centers, but to use the COPs and the implementation centers to get this information out to people. I hope that answers your question.
Thanks, Kyle. Feel free to type in the chat or expand on that if you need to hear any more, Mary, Sarah. And then there's just a comment from Eliza in Alaska. You know, I would also appreciate documentation on what providers are live with TEFCA Exchange. So I don't know if anyone wants to speak to that to any extent.
Chris, do you want to talk about any of the metrics that the RCE might be required to share with ONC? And I don't know if any of that's going to be public or when that might happen, things like that.
Yeah, so, you know, again, we're really at the early stages of, you know, TEFCA Exchange. And while we have, I think I might be losing track, but something like 6 QHINs that have gone live. You know, they're still onboarding people and stuff. And so, you know, we really don't know, you know, have all the details of who's all connecting and that kind of stuff. And ONC, in fact, isn't going to try to keep track of all of that. We're not going to, keep track of who signed up and who's not. That's just too much big government, in my opinion. But we will be getting some measurements, as Rachel mentioned, that will tell us like the numbers of transactions and the numbers of participants and sub-participants and those kinds of things. But because it's early, we're just not reporting on that yet. The RCE is collecting it, but we're not really doing anything with it at this point. We will as things get moving at a bigger clip, but there's just still a lot of onboarding and stuff going on at the moment.
Yeah, so I think unofficially, just to sort of parallel Chris's response, CDC, we're very interested in hearing who has joined, learning from those who have joined TEFCA, how they did it, what they did. We're interested and dedicated to documenting that, developing materials that can go be shared more broadly through COPs or through implementation centers. So because we do see that, outside of, I think it's not to what your point was, Chris, about we don't want to track people as in big government, and I agree. But we do want to make sure that from an adoption perspective, we're getting bright lights on people that are able to do it and that can share their experience and informations with others, so that they can also learn, how to, advance. So it's a little bit of a different angle. It's one that's really more rooted in education and outreach from our perspective.
Thank you both. I'm just going to share for anyone who didn't see in the chat, Katie Tully added when Kyle was speaking about kind of the COPs and lessons shared out. Katie expanded on that to say where helpful lessons learned from the early demonstrations may inform future updates to TEFCA SOPs also, where it's clear that additional technical guidance is needed to support a use case more broadly across the network. So just wanted to call that out as well. And I think that, oh, go ahead, Kyle.
Yeah, and it's a really good point. I think, going back to what Chris also said, we're in the early days of all of this, and we're going to learn a lot more as people start connecting, and being able to share those information, also to improve it, are critical. So working with CDC and ONC on what's working and what's not with TEFCA will be critical in terms of getting it right and updating future SOPs for public health to make sure that they are, getting public health what they need from TEFCA. So, over.
Thank you. I think that was all of the questions that we saw in the chat. Did I miss anybody? Great. We have this really brief poll just to kind of do a knowledge check on what you heard today. So we just wanted to ask you all if this information improves your level of understanding of the role of FHIR for TEFCA, just following Chris's talk. No pressure, Chris. This isn't, it just gives us some help on, where we might need to do any more resource guidance later. So feel free to share your thoughts there. And if it doesn't, please, in the post-meeting evaluation that Lux is going to post in the chat in a few minutes, please expand on that and what you need to learn more about, what sort of resources would be more helpful, those kinds of things. So give it just another minute here. Feel free to fill out the quick poll. Keeping you guys alive on a Monday morning or afternoon, depending on where you're at. Okay. I'm glad that it seems like for the majority of you that this really did help provide some clarity of that role. And again, for those of you who, still have a lot of questions, I know there's still a lot being determined, and this is a long road. We'll capture kind of anything else that you would like to hear about in that post-meeting evaluation. Lux, I think we can give it just another minute. Thanks for being honest. If you still have more questions than answers. Okay, I know we're just 3 minutes to the end. I do have a couple of slides I want to walk through, so we'll go ahead and end the poll. And see the results there. And then just a couple of you still looking for more. So thanks for participating. We're trying to keep it engaging here. I will move forward now though. So we did our questions. As in the last meeting, we want to always be kind of sharing out some example partner resources. Kyle already walked through the brand new interoperability website CDC has, but we did want to make sure for anyone who's not aware of this already, the Recognized Coordinating Entity, or the RCE, the Sequoia Project, does host public informational calls each month as an opportunity to share information about progress to date around TEFCA. So details on prior calls, including the slides and recordings, are available at this site. Lux, if you could drop this site in the chat just for anyone who doesn't have it, you're able to register for the monthly calls here, see those details on prior calls. And the next one is actually tomorrow. So just this morning, I received a reminder about the June 18th call. So if you're interested and aren't already registered, you can get more updates there. And then we would appreciate if you could take a moment to complete the brief post-meeting survey that Lux just put in the chat, and that just helps us get your feedback and collect suggestions for future content and resources that may be needed moving forward. So as you can see, just from all the things that we want to cover today in the discussion, we have a lot we're hoping to cover at the July and August meetings. So please feel free to join us to learn more about topics such as the status of the implementation centers, more on the pilots and use cases, new partner resources, legal considerations, things like that we're hoping to cover. And please do contact us if you haven't received these meeting invitations, and we'll make sure to reconcile that. And this is just, not everyone who's involved in this effort, but some of the contacts if you need to reach anyone. But there's also plenty of others that you heard from today and who are involved in in working on this COP behind the scenes. So thank you so much to Chris and Kyle for speaking today. Thank you to everyone for engaging through the chat, all the COP members, and we look forward to connecting with you in July. Have a great rest of your week.